So I'm Eldon Schriock. I've been practicing here in San Francisco since we were the third program to do IVF in the country back in 1983. I was professor at UCSF for quite a while. I trained about 35 or 40 fertility doctors around the country, and went into private practice in 2000, and that's when we developed the Pacific Fertility Center. And it's a practice of 6 physicians. The team is over 100 people now, of people that are your team members and helping you get to where you want to go. I personally had a big commitment to LGBTQ parenting. At the university, when I started all this, there was actually, as progressive as San Francisco may sound, there were still some pretty conservative ideas about, well, should we really be doing this? And so as soon as I took over the reins of the chief in 1995, first thing I did was had a big ethical conference, and we had theologians and psychologists and sociologists all come, and we talked about all these various ways to build families. And I really wanted to push the limits, and it was actually quite successful. You know, back then it was considered probably medically inappropriate to take an egg from one lesbian and put it into the other to carry. And I got all these people together and said, no, it's a great way to do family building. So that then became a way to go, when single parenting of any flavor was then very, very supported. So I think I became the medical director of one of the large lesbian sperm banks in town, and we've been a part of the LGBT community in terms of seminars and supporting all kinds of social events for a long time. So there's a huge commitment, and it's not just professionally, it's also personally for me. I think it's a big deal. So that's sort of some of the emotional basis. The practice itself is a very mature, sophisticated IVF practice. I think it has the advantages of being one of the larger programs in the country, but also the advantage of being small. We always haven't had that, but it's something that we developed. We have a tiered system where each physician has their own personal team. And so if you happen to be my patient, when you call to speak with a nurse, it's your nurse. And it's my medical assistant and my coordinator. Even though there are 6 of them in the practice, that vertical team is there. We always try to schedule doctor priority scheduling. You know, our doctors still do, as big as they are, still do all the ultrasounds, transfers, et cetera. And so your gestational carrier and your donor probably will be screened by me. I don't work every day of the year, but most days. And so that also is a very consistent message. We also do much of our communication by email or phone, which also makes it very convenient for you. I think, you know, there are some things that are the advantages of being a larger program. One of those is having access to the latest gadgets and all that sort of stuff. I was at UCSF for a long time, and by the time I got my budget request for the new latest laser, whatever I needed, into next year's capital budget, and then by the next year it got funded, it was old news. And so a lot of reasons like that, we are in control of our own destiny now and can have the latest and greatest there. Plus a lot of the new technology coming down the road has brought us to beta test, and so if there is something new and fancy, we'll probably be doing it. The other advantage of being a large are accuracy is in the lab. You probably heard this at many of the talks. What makes a program is the lab. We're all proud of the lab. I'm the doctor that kind of runs our lab. And I think that it is the thing I spend the most time on over the years to get perfected. But the players there that are really good are embryologists. Dr. Joe Conahan is our head embryologist. He's been doing this for a long, long time. We recruited him from London years ago, and he's considered a leader not just in this country, nationally, internationally also. But the other thing that's important is to have a lab large enough that its attention to detail in terms of chain of custody. And in our lab, before any sperm or egg or embryo anything happens to it, it's a double to triple sign-off. You'll find out when you come in. If you give us a semen sample and there's not a name on the cup, it gets discarded, you get to do it again. You know, when you'll be there when we transfer the carrier, she has to personally say her name, and you have to say your name and birthdays to the embryologist before they'll do the transfer. So, but in the side, that's what you see, but inside the lab, it's much more important. If there's ever a mistake made in an embryo laboratory, it's usually one that's just 1 or 2 embryologists that are there, and there's not that checks and balances. So the size thing has importance all the way around. Common question is why then do you pick one program or another? I think this is one. It's hard to evaluate a lab. Some specifics, though, I think are there. Over the years, a lot of programs didn't make the transition to doing what's a long-term culture. You know, transferred embryos on the second and third day for a long time, but many years ago we started saying blastocyst, this day 5-6 transfer is the way to go. And we've, I think, perfected that now. And we've taken it one step further. In most laboratories, if your embryo has to become a blastocyst, and you've seen a picture, it looks like a soccer ball with the baseball inside. It's got 150 cells. The soccer ball is now placenta, and the baseball inside is baby. This is when we can now biopsy the embryo, which is the placenta, the soccer ball on the outside, safely and not mess with the cells that are going to become baby. So your embryos have to make it to that by day 5 or 6, or the extra embryos that are growing slower are discarded. So far, I think we're the only lab in Northern California, at least that I can keep track of, that gets babies from day 7 embryos. You have to have a lab that's really good. So everybody said we got a great lab, and we all do, but this is a specific example of how I think ours is set apart, because it's really hard to maintain that quality control for another extra day, a full 7 days, and we've actually reported our results in the meetings of our day 7 babies that have been born. So every embryo then gets a good chance. So it's another message about what you could expect, but it also helps you give something specific of, well, everyone says their lab's great, but what does that mean? The next part of making this work, and especially in the path that you are going to take, is you have to have a program that freezes things well. Our pregnancy rates from frozen embryos have been better than fresh now for almost 12 to 15 years. And part of that is because we just, sometimes I think I get lucky, but we made a big decision before most other people did about 12 years ago that the old what's called slow freezing method wasn't the future, and that this new technique called vitrification was. And we found a guy who was vitrifying mouse embryos at University of Michigan, happened to be a buddy of my embryologist, brought out here, and we said, this is the way to go. He said, look at these embryos after I've frozen them. Don't they look beautiful? And they did. So we did. We got on that. We were part of the, again, beta testing to get that product. So we jumped on the vitrification wagon real early. Well, what does that mean? Example, well, we used to freeze embryos, and when we thawed them, we'd lose maybe 20%. With vitrification, we're now down to less than 2%, 98 plus survival in embryos at PFC. So the other thing that did is an example of the quality of these embryologists babysitting your embryos is that the egg has been the hardest thing to freeze. We froze sperm decades ago well. We froze embryos now for quite a while well, but to freeze eggs well, it's only been about the last decade, about the last 10 years. And what made it happen was vitrification. So I said, here we go. We're going to be able to freeze eggs. And it turns out we have. And so far, we're the only program in Northern California that has an egg bank. And not only do we have one, but as you heard maybe this morning, we have been up and running for 5 years, and there's not another one even started yet. And we are so confident in our embryology techniques that we have a day 5 blast guarantee in the egg bank. Now, that may apply to you guys if you decide to go down the path of getting frozen eggs. You know, I think I said earlier, you can buy some egg banks just sell you eggs and kind of say good luck. Some people that are doing embryo guarantees will guarantee day 3, 2 day 3 embryos, because it's pretty easy to keep them happy until then. Also, only about 60% of the embryos that look good on day 3 will still be blastocysts later. But we actually guarantee 2 blastocysts. So there you're putting a lot of things together. You have a lab that can keep embryos happy and go out to blastocysts that we're confident of, but you also have a lab that then can freeze and thaw them well at that point in time, enough that we can say we promise, we guarantee that you'll get those blasts. So the next sort of piece of an example of why the lab works well is embryo biopsy. I did the first embryo biopsy of my patient in 1995, so a long time ago, over 20 years ago. And you know, back then, the only things we could test for actually were the X and Y chromosome. And so why did we do it? Well, it wasn't to pick out boys and girls, which we do now all the time, but then it was to prevent muscular dystrophy, because all the boy embryos would die because they'd get muscular dystrophy. So we would do it to pick out a girl embryo, not picking out a girl, but to pick out a healthy child. Oh, well, it's developed. We then got 21, and then we got 7 chromosomes, and now we're complete. Check all the chromosomes. The test is essentially as accurate now as the amniocentesis. I think it is completely safe to do the embryo testing. I don't think the embryo is damaged. It's very important, though, that you don't go to a program that's still testing the embryos on day 3. that's really bad news. We could have done that 15 years ago. But testing a blastocyst is really very accurate and safe. I think if you're using a donor egg, it becomes controversial how important it is. The success rates in our hands with an untested embryo or high 60s, 70s, but with a tested embryo, you can start to get to 80 with just one embryo. So it does improve, because even in donor eggs, you've heard there's some that don't have good chromosomes, and you can't see that. An embryo that's going to turn into a miscarriage is gorgeous. Down syndrome, gorgeous embryo. You can't see that unless you test. The good news, in a 25-year-old, Down syndrome was maybe 1 in 1,000. And so I think in your setting, doing the embryo testing is optional. It can improve your efficiencies of cost for your GC, because your cost per transfer is going to be the same, but you'll probably do less transfers if you have a tested embryo with over 70% pregnancy rate. But why is it that people, I always guess maybe half my gay couples are testing, and I get it. I had a boy, and I wanted a girl from number 1, and luckily she came on number 3. I get family balancing, I get choosing sex. I think that is something that, again, years ago, because we were the first to be able to do it, it actually ended up in the San Francisco Chronicle, editorial place, pluses and minuses, should we allow this, should we not? And of course, it's now common in our program. We will ask you to decide if you want to know before you start, because in the past, we would say, do you want to know? And you'd say no. So we would get the report. You've got 6 normal embryos and 3 boys and 3 girls. And then we would try to keep it a secret. Well, we suck at secrets. So you guys have to decide ahead of time now. If you don't want to know, I don't want to know. So the report just comes back normal. But obviously, that's completely up to you. The other beauty of freezing embryos is once they're frozen, which they're not anymore. What vitrification is, it's fast freezing. Instead of, when you freeze anything, you have to get all the water out of the tissue you freeze, because the little bit of water left in turns to ice when you freeze. And ice is nasty. It's like a glass crystal inside of the egg or embryo, whatever, it does damage. The physics of vitrification is fast freezing, and a little bit of water turns to Jell-O, a super cool fluid for you physicists out there. And so imagine Jell-O instead of ice, you want Jell-O. And so that's why it really, really works so well. But once they're in the liquid nitrogen, time stops. So that embryo or that egg doesn't change in its chance of turning into a healthy child ever. And there's a lot of good data now on frozen embryos, no increase in birth defects of any kind. And I think the data set is getting almost, we've been using frozen embryos for 30 years, frozen eggs for 10 or 15, but so far so good too. It's all good news. So you'll have lots of choices. That's talking about the lab in terms of decision making. I think then, as I said earlier in the general conference, feel like I'm a general contractor. I think really we will provide input on all of the levels. We don't actually have a pool of surrogates, but we work with all of the major surrogacy agencies and can make recommendations of who we had success with. Our egg donor agency, if you find a donor in our pool, I think a lot of people are really happy. The donors are screened very thoroughly. It's kind of a one-stop shop. It makes it really easy. There are financial advantages. When you talk to agency, they'll talk to you about the pluses and minuses. All of our donors are screened by geneticists. I think that's critical. We're going to really wade you through the genetics counseling. You'll meet with the geneticist yourself in-house on our staff. That's all really, really important too. So having those team players, you'll have your own individual coordinator or nurse that will also hold your hand to go through all this. We have our own in-house counselor, great free visit for everybody to talk about any kind of parenting questions you may have left that you haven't come to a nice conclusion with yet. I think, though, going forward, the next hard decision, and sometimes I think it might be the hardest decision, is do we transfer embryos 1 or 2 at a time? You've heard a lot of talk about that. I was married to a pediatrician, and I got scolded for years of all these sick twins that we were making. So we flipped to a single embryo transfer program a long time ago, 12, 13 years now, I guess, and started encouraging, please, 1 at a time, 1 at a time. And now we're 95% or so, no matter how old you are, where the egg comes from or whatever, we're transferring 1 embryo at a time. I can scare you to death about the risks of twins, their health. Cerebral palsy, 6 times higher. 90% of them are preemie babies. There's a higher chance of autism in twins. Even if your twins make it to 38 weeks, which is considered normal, their reading scores in 2nd grade are going to be a little bit lower. That's the scary side. The upside is most twins are fine. But if you do the comparison of 1 at a time to 2 at a time, you're going to find a higher incidence of problems on the twin set. But it's really obviously expensive to go through. So I will struggle with the decision with you, and we'll make it together. If you ask me, Doc, what should I do? I'm going to say one, because I know the value of parenting healthy children, and that's really what our motto is, actually, one healthy baby at a time. So it's a journey. It sounds daunting, but hang on to the excitement of this. You'll get there. You'll be on the other side looking back. Having done it 35 years, I see it all the time. So do we have some time for questions? A minute and a half. Okay, I better quit. Questions? Yes, sir.
So if you have identical twins, like we talked earlier about kind of reduction, there's selective reduction, and you say, no, I only want one, but the egg splits and all of a sudden you have two.
Yeah, it's very hard to reduce an identical twin from 2 to 1. If you put in 2 embryos in one splits, then you have identical twin triplets. And then typically what they'll do, they will reduce the identical twins to save the triplet to the third. The identical twins are also 2 types. They're in the same sac or separate sacs. In the same sac, it's much more risky, and those pregnancies sometimes get reduced just because of that increased risk. If your twins are in separate sacs, and as identical twins, their risks are very similar to fraternal twins. You don't want to be in that situation anyway, but identical twins still happen. I pull my hair out, but we can't seem to prevent that. So it's still around a 1.5–2% chance. Another question? Yes, sir. Yes. The cost, the only advantage, I say this over and over, the only advantage of freezing eggs and using an egg bank is cost. There's really no other plus. And you balance that, but if you only want one child, it's probably a really good deal. And if you don't care if it's a boy or a girl, then the egg bank is probably great for you. Because out of those 2 that you get, there's a high chance, it's 85% chance you're going to get what you want, one healthy child. In our program, the lab freezes, thaws some eggs, they use your sperm, they start making embryos until they have them. We may thaw 6 eggs, you get 4 embryos, then you have 2 bonus. They're just there for you to use. If you want 2 kids, the egg bank starts to maybe be a balance. You could get 2 out of the kids, but the fresh program probably is a better deal. And if you want to do genetic testing, then you can only do genetic testing with fresh eggs.